Good afternoon, everyone. Today in this Cuddles one session, I'm teaching about POCUS in shock. It's a point of care ultrasound. I'm covering about the basics of views and what are the things that we can rule out by eyeballing the heart and vessels to determine which type of shock it is. I'm Dr. Kalyan. I'm pediatric intensivist at KIMS Cuddles, Kondapur. This presentation would be more oriented towards pediatric ICU, and some of the principles can still be still hold good for neonatal shock. So, have disclosure. Most of the ultrasound videos are from some of the POCUS training modules and from our hospital collections. The outline is introduction to the point of care ultrasound, what would be the learning curve that is needed, and the views that we need to be well versed, and what is the quick protocols that are there and which are very much tried and having a lot of literature on it, and then how can we simplify our approach to the bedside. So in the last decade, POCUS has become a part of an ICU examination, and most of the pediatric ICUs, the quality units, do document what are the POCUS findings along with their rounds. And in very sick kids where the fluid management is tricky, the POCUS helps when it is monitored very frequently. In critical care, complete physical examination is very, very tough at times when the child is having multi-organ dysfunction, having sedated, limitations in moving the child, limitations in examination. Ultrasound always plays a complementary role and also gives us the thoughts that we might miss on our physical examination. The advantages is it is portable, reproducible, you can compare, doesn't have any radiation, and it doesn't need any expensive consumables. We as pediatricians, can we do it? Yes, we can do it. Though we are not a trained radiologist, we can do it as a functional screening rather than going into the details. And in most of the scenarios, undifferentiated shock is the most common challenge, and most of the times we won't be getting enough time to call up our radiologists to differentiate between the different types of shocks. And POCUS per se is a quick and qualitative analysis, and it need not be to an extent like where you are counting the LV mass, then coronary indices, all those things. You are just eyeballing the function to help you to aid what is the next step that you can take. And in a trial where they have given a brief formal training of transthoracic echocardiography, around 84% people interpreted it correctly for the functional screening. So to do it, we need to know the surface anatomy. The heart is located onto the left, into the center, and oriented towards the left side, in the midst of the chest, and with lungs on either sides. So your approach could be from the down and from the up of by your probes. So what are the windows that you can use? So the first one is parasternal window. Parasternal, you have two windows, parasternal long axis, parasternal short axis. Then the apical window, where you are shooting through the apex to reach out to the four chambers. And by meddling the probe, you can even get the fifth chamber, which is the aortic. Then the subcostal route, which gives you a good angulation for the pericardial collections. Then you can see the four chambers. You can also see the IVCs, and this through the suprasternal notch, which is the best view to assess the aorta. In parasternal long axis view, the plaques view, here the indicator is towards the right shoulder, and you are placing your probe, the phase array probe, towards the right shoulder in the 4th to 5th intercostal space. You are cutting the heart through the RV into the LV, and the lowermost part is the descending aorta. So here you will be seeing a part of RV, LV, and LA, which is opening into the LV, and a mitral valve and aortic valve opening. You can judge how the LV is contracting and what is the proportion of LV that it is to the RV, and whether LA is dilated or not, and what are the motions of mitral valve and aortic valves. So this is a good view of parasternal long axis view. You are seeing a part of RV, you are seeing LV, apex is not included, and you are seeing this mitral valve is very well moving and almost opposing to the interventricular septum. In a rough way, in the bedside, you can place a small finger in the LV and see whether all the walls are reaching towards the towards your finger in the systolic movement. If it is so, then there is no regional wall motion abnormality and the contractility is being good. Parasternal long axis view is just perpendicular to the parasternal long axis. In the parasternal short axis, you are cutting the ventricles just cross-sectionally. You are going to see the two chambers. In this, there are, with the tilt of the probe, there are 3 levels. One is, you can say, if you are seeing the apical sort of VSDs and all, you can have 4 levels. At the apical level, mid-papillary level, mitral valve level, and aortic level. So you are putting the probe just perpendicular to your plaques view, and then you are slowly tilting your probe to reach across these levels. What you are going to see is like a big muscular rounded chamber, that is the LV, and abutting to it a D-shaped chamber, that is the RV. So if you compare, the RV size is always less than the LV and should be less than the 2/3 of the LV, and LV need to be muscular, and the interventricular septum should be towards the RV, because LV pressures are the higher pressures. So if there is any reversal of this, like RV becoming right ventricular looking bigger or almost the same size of an LV, or interventricular septum is being pushed towards the left ventricle, it says that there is an RV dysfunction. In the same view, like what we said in the plaques view, you can imaginarily place a finger at the LV and see whether all the walls of the LV is reaching towards your finger, which says that there is a contractility, uniform, and good. So this is at the mid papillary level. You are seeing the papillary muscles, LV contracting really well, and RV is D-shaped. LV is good muscular, and interventricular septum is moving well. Then coming to the apical views, apical view, you place your probe at the where you get the apical impulse, and your pointer is towards the left shoulder and cutting the shadows through the right ventricular left ventricle towards the atrium. Here you see RA, RV, LA, LV separated by the tricuspid and mitral valves respectively. So these are the views which you can use to check for the Dopplers across the valves. And once you get the 4-chamber view, you tilt it caudally. You are going to open one more chamber, which is called a 5-chamber view, and which is nothing but a LV going through the left ventricular outlet and the aorta. So here you can check for the velocity time. You can put a Doppler to check for the flows across the aortic valve and do a velocity time integrals. Then coming to the subcostal view, it is most easier view and the first view that you can start approaching, where you can roughly see all the four chambers along with any pericardial collection. And this is one of the view which can also throw up a light on what's happening to the atrium and any ASDs are present soon after you put it. So here you see your indicator is always onto your left. You see the right atrium, right ventricle, left atrium, left ventricle, and if you increase the depth, you can also see the openings of your pulmonary veins, which you could see on the Doppler, but which most of the times is not included in the assessment of shock in pediatric age group. It's not moving again. Okay, great. So this is the subcostal view. You are using the liver as your window. So if you should always approach onto from your right side towards the heart, because if you approach from the left side, it's a stomach shadow. You won't be seeing any of your heart chambers well. So here, liver is your bigger window, which opens up to pass your ultrasonic waves across to see the heart. You're seeing RARV, LALV, and very nicely contracting heart here. Then coming to the IVC views, so here your pointer is towards the up, and you place it. You place it in the subcostal, just parallel to the position of the IVC, and slightly tilting towards the right side. So one way to do it is you put your subcostal view and slowly tilt it perpendicular to the subcostal view. You are getting the IVC view. So here in the ultrasound view which we are giving, initial view is a subcostal view, and slowly I'm tilting, and you are getting a nice tubular structure that is the IVC. So how to differentiate between the IVC and the aorta? IVC is seen onto the right side. IVC lies inside the liver, and IVC is most of the times not pulsatile. And aorta lies outside the liver, abutting the spine shadows, and is pulsatile. So in this image, you are seeing the IVC that is opening into the RA, and the hepatic part of the IVC with each breathing, it is collapsing, which says that you can fill some volume into this IVC. This is the just a contrasting picture where you are seeing the IVC, and the vessel that is coming through the liver entering into the IVC, it's the hepatic vein. So this, with each breathing, there is hardly any movement, hardly any collapsibility of this IVC, which says that the IVC is well distended, and probably the child might be fluid intolerant or fluid overloaded. So coming into your approach of the shock, so there are 4 types of shocks: hypovolemic, cardiogenic, obstructive, and distributive. So though it looks like the classification is so simple, for an instance, we can take one type of distributive shock, which is a septic shock. So septic shock at various phases can be any part of these things. So a septic shock with in the initial phases can be hypovolemic shock, and a late sepsis can cause cardiac dysfunction, can become a cardiogenic shock. And the same septic shock, when there are effusions or empyema, it may progress towards the obstructive shock. So similarly, in a case which is there in the ICU, landing up in shock, whether it is a new onset, whether the child admitted with shock or you have improving and then landed up in shock, it is very difficult to ascertain just with clinically that child has only one type of shock. So you need a structure, and you also need a lot of monitoring to say which type of shock is more than the other or which type of shock is ruled out. So one of the protocol is the rush protocol, which is mainly derived from adults and which is used in emergency management of shock. So the circulation per se is divided into pump, tank, and pipes. The pump is the heart. Tank are the is basically your preload. The pipes is the aorta. Rush protocol can subcategorize the shock syndromes, which is the flow, the pump, the tank, the pipe. So if there is a problem with the pump, that is a cardiogenic shock, the heart is not moving well, the heart is dilated, which says that acute heart failure. The tank is basically the preload. Preload, which is child is dehydrated, your IVCs are small, you are having hypercontractile heart, so that assesses your tank. So the preload. Then is the pipe. The pipe is basically you are having a poor vascular tone, which is causing a lot of which is per se is reducing your preload as well as your SVRI that lands up into distributive shock. Septic shock is one of a distributive shock. Then at the last comes the flow. So your preload is good, your pump is good, it is hypercontractile, but still you are not going to see the BP because there is a big pressure across the heart to the vessels. That is called the obstructive shock, which is seen in pulmonary embolism, tension pneumothorax, cardiac tamponade, all those things. So in the rush protocol, what are the things you are going to see? Pump, you put your plaques view, sacs view, see the LV contractility, RV strain, and rule out the tamponade. And you do the tank by seeing the IVC variations, and you see the leaks, which are the effusions, you see for the tamponades, and any bleed. Pipe, not very common in pediatrics. You look for aneurysms, you look for aortic dissection. I'll be coming into the examples of what are the things that we see. The other approach is called an high map approach. High map approach is an mnemonic, basically. H for heart, you see for the cardiac views, I for IVC, M for Morrison's pouch, which is EFAS. High map is more commonly used in the trauma. Morrison's pouch, you check for the effusions, you check for the you check for any hemoperitoneum things. A for aorta and deep veins. Deep veins for DVT, and aorta is for any aortic aneurysms or dissection. P is for pneumothorax, pulmonary edema. So let's go through the high map approach. So in the heart, you see for the plaques view, you see for systolic function of the heart. So here you see on to your left, there is a normal contractile heart. So you are seeing RV, you are seeing LV. LV walls are approaching each other, and mitral valve is almost touching the IVC. On to your right, you are seeing a hypercontractile heart. The LV walls are almost kissing. And you see the mitral valves are moving really well, and there is no pericardial, no or minimal pericardial effusion. This says that this child might have low preload, and you can give volume. So now coming into the next views onto the left, you are seeing the heart is looking to be tachycardic. the LV is hardly contracting, low contractility. The mitral valve is opening but not able to touch to the IVS. So this is a moderate dysfunction. Onto your right side, the heart is barely moving. Your mitral valves are barely touching, and the excursion of mitral valve is very minimal. So which says that there is a severe dysfunction, severe systolic dysfunction. Then you change your view, just perpendicular, that takes you to parasternal short axis view. Parasternal short axis, this is a at the level of papillary muscles. Your LV is good, RV is good on the left window. Now you are coming onto the right window. The proportion of the LV and proportion of RV are just reversed. RV is looking huge, LV is looking D-shaped, and now you are seeing that you are having a paradoxical movement of the IVS, which says that the child is having RV strain, or you can say child is having higher pulmonary pressures and RV dysfunction. So then you change your probe onto subxiphoid view, or in the initial views also you can know about if there is any pericardial effusion. So how will you know about it is a pericardial effusion or pleural effusion? So in your plaques view, the lower part of your window, the circular one is the descending aorta. The effusion that is seen above the descending aorta level is pericardial effusion, and the black shadow that is seen behind or posterior to the descending aorta is more likely to be pleural effusion. So this is one of the image which shows that the heart is floating like a jellyfish in the pericardial effusion, which is impending to be tamponade. You see the RA. So with each diastole, see how RA is getting collapsed. The size of the RA is getting collapsed. So this signifies that the child is having a tamponade. So now you see, like at this point, at the first point when RA is being collapsed, you have not intervened. Then the next step is the RV is being also collapsed. What happens when the RV collapses is the late phase of or almost peri-arrest situation where you are seeing when RA, RV both are collapsing in a pericardial effusion. So next is the measurement of cardiac output. So you do a plaques view, you'll get the aortic diameter at the aortic rim. So that gives you the LVOT area. So you know pi d square by 4, or that's the formula you use for the LVOT, and then you go to your 5-chamber view, which I have shown initially, and then you place a Doppler across the LVOT and to activate the pulse wave Doppler. So you get a wave something similar to this, and then you whatever be the wave that is presented during the systole is the output. So you trace it. That is called velocity time integral. The velocity time integral, you record it in centimeters, and you get the stroke volume by placing it to the formula by area into VTI, and you check the heart rate at that point. Heart rate into the stroke volume gives you the cardiac output. So that finishes your H of high map. Then is the IVC. So in the xiphoid view, you can in a glimpse you can check whether the IVC is collapsing or IVC is distended. But at times it is somewhere in between. It looks to be collapsing when the child is taking a deep breath. So what you do is like you place an M mode across the IVC to measure the maximum and minimal diameters, and you check for the collapsibility index or a distensibility index. A collapsibility index of more than 12% gives that says that the child might be fluid responsive. In ventilated patients, we use distensibility index. Only thing is like the denominator we change from the mean to the minimum, and a distensibility index of more than 18% is likely to be fluid responsive. One thing to remember that this giving boluses by just a measurement of IVC is not a foolproof method. IVC per se is influenced by many things like intra-abdominal pressure, deep breaths, and high PEEP on a ventilated patients, all these things. So a fluid responsive on IVC doesn't mean that the child might not be fluid intolerant. So even after measuring the IVC and you are giving, it doesn't ensure that you can stop monitoring while you are giving the fluid bolus. So in spite the collapsed IVC, whenever you are giving fluid bolus, you still continue to see whether the child is having any features of fluid overload. So based on the things like H and I, we can actually differentiate to certain extent which type of shock the child is having. In distributive shock, the heart will be hypercontractile, cardiac output will be high, and IVC is collapsible because there is a third spacing. In obstructive shock, the LV is struggling, so it tries to pump as much blood as it could. So you can get in the initial phases high ejection fraction, like hypercontractile heart. At a later phase, it can reduce. The cardiac output, what you measure, the stroke volume and VTIs will be low, and IVC, because of the tamponade effect and right-sided diastolic dysfunction, your IVC becomes non-collapsible. In the cardiogenic shock, both ejection fraction as well as cardiac output becomes low, and because of the back pressures, IVC becomes non-collapsible. In hypovolemic shock, IVC is collapsible, cardiac output will be low, and LV will be hypercontractile. So with this table, we can roughly gauge like which type of shock the child has, and then can take quickly the measures to come out of the shock. And getting those two steps usually takes like less than 5 minutes. Then M is the Morrison's pouch, which most commonly we use in trauma or post-surgical. So here we place the probe in the right and left hypochondrium. We see the first the uh, pointer towards the shoulder, and the first bright line is your diaphragm. The above the diaphragm, it is the lung shadow. Below the diaphragm, it is either liver or the spleen shadow, depending on which side you are doing the sound. And just beneath it is the renal. So if there is any collection between the spleen and kidney, or between the liver and kidney, it says that the Morrison's pouch is filling and there is a intraperitoneal fluid collection or a hemoperitoneum. So the first one is on the right side, the second one is on the left side. You can nicely see that the lung is moving with respiration, and left onto the left side of the screen, it is the liver and kidney. Onto the right side of the screen, it's the spleen and the kidney. So here, all the lines are very much together, and there is no shadow in between the lines. So we can say that there is no collection. So here you see, on to the left, we are seeing that there is a collection around the kidney and between the liver, which says that the Morrison pouch is full and this child had hemoperitoneum. The same child we were screening, and now you can see some of the strands across the this across the spleen as well. That is, we can say that it is those are changes of hemoperitoneum. So we have finished M. Next comes to the A, which is the aorta. Aorta, very less likely we see the aorta unless it's a high velocity road traffic accidents involving the compression of aorta. In the aorta, what we see is the aortic aneurysm, aortic dissection. Here you are seeing uh, a hyperechogenic structure which is floating inside the aorta in the ultrasonic image. which says that there might be a dissection. Uh, uh, Sometimes, like when we see any child who's having a PDA open and presenting in shock, so is it because of the PDA, more flow through the PDA, the child is having distress or not? Is there a diastolic running? So in the same window, what we can do is like you do the aorta, uh, you do the window, same subcostal window, tilt onto the left side, you see the nice tubular structure, that is the aorta. You put a color. If there is a color flow reversal, that there might be a diastolic reversal, and then you put a Doppler, and during the diastole also you are seeing the like instead of a single phase flow velocities, you are seeing a double phase, like even in the systole as well as the diastole you are seeing. That signifies that probably uh, the the shunt, the left to right shunt is too huge, causing a diastolic runoff. P is for pneumothorax. For pulmonary, so a linear, we change the probe from the phase array to a linear probe. We see, we go across the lungs. The mid one is the lung shadow, which is nicely sliding. On either side would be the ribs. This is called the bat wing appearance. And you see for the sliding, here you are seeing that the pleura is nicely sliding, right? And on M mode, you see like the upper part of the planes is not moving, so you get a straight lines, and the lower part is slightly having multiple layers of muscle layers. So you see a streak of lines, and then because there is a sliding of the pleura, you see multiple shores. So this is called a normal lung sliding with a C shore that is seen on the M mode. So now this is one window. Like in pneumothorax, what happens is the lung can't move, and in between, whenever there is air, it can't traverse. I mean, the ultrasound waves can't traverse well. So here you're not seeing a lung sliding, and when you put in the M mode, what's happening is, because there is no sliding, because so there are no further dots, like a beach appearance is not coming. So this is called a barcode sign. So, and the place of isolation where there is some amount of movement and where the movement is lost, that is called lung point. So identification of lung point signifies that there is a definitive, it is definitive of pneumothorax. And if we couldn't, in some cases where we are ventilating with high maps and all, sometimes the lung sliding becomes tricky. You need to zoom in, and you need to find the other variables. So in a way, presence of an B lines suggests that very less likely that there is a pneumothorax at that point. So what is false protocol? It's a fluid administration limited by lung sonography. It's an extension of a blue protocol which is used for hypoxemia. It is assessed for used for assessment of shock and categorization based on the lung artifacts. No need for any advanced Doppler or color that is needed, and it adds to the fluid intolerance. Like as I said, IVC might be collapsing, and you give, and you are seeing a lot of B lines on the lung, that says that the child might be fluid intolerant. So what does false protocols say? Like acute circulatory failure, you do a simple sonography and cardiac sonography, rule out tamponade and pulmonary embolism. You do a lung ultrasound, you have ruled out pneumothorax. So tamponade is ruled out, so there is no pericardial effusion, there is no pneumothorax, so that more or less rules out most of the obstructive shock. And then you see whether there is an A profile or a B profile on the lung ultrasound. If there is an B profile, that says it is a cardiogenic shock, most probably the lungs are wet because of the back pressure. And if it is just the A profile, then you classify them into false and give fluid. With fluid, if your assessment is improving clinically, it is a hypovolemic shock. If there is no improvement and a B profile is being generated, the child is becoming fluid intolerant, or probably it's a septic shock. Uh, I'll I would end with okay. Interact అవుతారా లేదు, it's a one way. Okay. So I would end with a simple example of how exactly that we can differentiate using the focus. An 8-month-old infant presented with history of cold and cough for 1 week, no fever. In the ER, he is found to have fast breathing, lethargy, and mom complains that the child is not taking any feeds. So on ABCDE assessment, airway is patent, respiratory rate is around 70, and subcostal retractions are present. Saturations are 88% in room air and 97% in the 2 liters of oxygen. So definitely there is a respiratory distress with some failure. Heart rates are 180, steady pulses, CFT is prolonged, lower limbs are cold till thigh, and BP is overall 70 by 54, very narrow pulse pressure, but acceptable for the age. And the liver is around 3 centimeters. GRB has been okay, child is been irritable, and there is no history of fever. So, move over. Okay. So here, you know that the child is having distress, your child is having perfusion issues, so cardiorespiratory involvement, more likely to be cardiogenic shock. But because there are uh, uh, no history suggestive that how much urine that the child has passed, and there are poor oral intake, so the resident wanted to give a close fluid bolus. So a close monitored fluid bolus has been given of 5 ml per kg, and then she has taken a help of a POCUS. So what are we seeing on the POCUS in the on the IVC measurement? So here the IVC is well distended, even the hepatic vein is very well distended. So your IVC is distended, and then the next shadow comes in. See the LV. LV is quite distended, poor function, and mitral valve is hardly opening. So it's a case of cardiogenic shock. And in the same window, you see the retrocardiac B lines. So that means the lungs are also being wet. So at the end of 5 ml per kg fluid bolus, what has happened? The heart rate has reduced by 2 points. The BP has a bit worsened. Liver uh, liver size increased from 3 centimeters to 4 centimeters. Perfusion is still the same. The retractions worsened and saturations fell down from more than 95 to 90%. So the child is fluid intolerant and in cardiogenic shock. So what is your interpretation in the fluid resuscitation? It is the child is fluid intolerant. And what vasoactive agent that you would consider? You would consider an inotropy at this point, that is adrenaline. So when you go through the flow chart of high map protocol, with practice, most of the times around 5 to 6 minutes is what it is needed for you to get the initial complete assessment. And with practice, you can further shorten it down. And many literature says that a proper proper protocol of rush and falls uh, should be taking around 5 minutes, and by completing around 25 examinations, you get more reproducible results. So whenever you have a ultrasound in your unit, do ultrasound every child irrespective of whatever be the pathophysiology, and get well acquainted with what are the knobs, what are the parameters that we use, so that when we see any abnormal, uh, it just needs an eyeballing rather than doing multiple calculations. Thank you.
input.